All right, welcome back everyone to another virtual shouting session at Hearts for Health. We hope your year is coming to a nice close. It's almost the end of the year. Pretty insane to think about. 2023 has gone by pretty quick. But today we're joined by Flora. She's a PA practicing family medicine in California. She'll be talking a little more about her journey, what it is to be a PA, the specialty too, and we'll see some cases, which I know y'all are excited to see. I do have some reminders though, especially if you're new to our program. I just want to give y'all a quick breakdown of our structure. Each of our sessions lasts typically an hour. We have speakers like Flora and many others across the health professions. Our virtual shouting program is for pre-health students in general. So you could be pre-PA, pre-dental, pre-med. We have speakers for you in those professions. And once our speakers wrap up with their presentations, we have time for a Q&A at the end. So if you happen to have any questions for Flora along the way, feel free to type them in the chat and we'll get around to them at the very end of today's session. Also, if you would like to stay tuned with more shouting sessions, we have one at the end of this month. I believe it's November 20th, and we're hoping to have more come our way. We usually have these sessions on either a Monday or a Thursday at 7 p.m. Central. I would convert that time zone if needed, if you're on the East Coast or the West Coast, or maybe in Mountain Time. But in order to stay tuned with those sessions, we have our Instagram page. That's one way to get connected with us. We post our flyers on our Instagram page a couple days ahead of time. And we also have our listserv, which is sent out each Thursday morning. It's an email listserv, including those same flyers and maybe a couple other opportunities from time to time. We have some volunteering programs outside of our virtual shouting program, and we'll actually be releasing those soon, later this month, or maybe even within the next few weeks. But those volunteering programs are posted on our website in case you would like to hear more about them. Hearts, the number 4 health.org. That's the URL you can go to for our website. I don't want to take up too much time. If y'all have any questions about what I mentioned or outside of what I mentioned, feel free to email us. I will include our email in the video description at the very end of today's session, and we're happy to answer any questions from there. But with that said, Flora, feel free to take it away.
Thank you so much, Michael and Natalia. Thank you for having me. I'm really excited. So my name is Flora. I am a physician assistant working in California, Central Valley to be exact. So I'm excited to be here and kind of give you a little inside scoop of what it is like to be a family medicine PA. So to start off, my name is Flora Rodríguez. I am working in family medicine in Cutler, Rossi, which is a small rural town here in California. So my population of patients is vastly uninsured, underrepresented. They have a lot of, health issues going on with them already because they do live in such small community. A lot of them are undocumented. So it's nice to be a part of a community where I'm able to help and give a little bit of insight to these patients who otherwise might not be able to see a provider. I was raised in Fresno, California. I went to Fresno State. I decided to stay local for my undergrad. I graduated in 2017 with my bachelor's in psychology. During this time, I was also part of one of the local hospital volunteers, and I also volunteered with the Doctors Academy program, which was a program for high school students who were looking to go into the medical field. I was also part of HCOP, which is a Health Careers Opportunity Program, and thanks to it got me to where I am today. And a lot of the mentors that I had were through this program. And then in the meantime, while I was there, I was also working as a second grade tutor, which I really loved. I feel like if I didn't go into medicine, I think maybe teaching would have been my second option. I did take a gap year. So during this gap year, I did become a CNA because I needed hours for PA school, because for PA school, patient care experience hours are required. So I was a CNA for a year in the nursing home. During my second year, I decided I needed a little bit of change. So I decided to go into med-surg department at a hospital where I felt like I was exposed to so many different diseases, disorders, surgeries, and it was just a very eye-opening experience for me. During this time, I also did some pre-reg classes. So I just think I needed like human anatomy and physio. And then I just focused on trying to get more science classes in so I could boost up my science GPA, because that was one of my weaknesses on my application. So a lot of people ask me for my stats sometimes. So I like to share it because it just kind of shows that you are more than just a number. So my science GPA when I applied to PA school was a 2.9. And so for a lot of schools, they don't take that GPA. And I was very lucky that my dream school, which was UC Davis, accepted this GPA and they gave me a shot. And now I'm here. So I did graduate in 2021 from UC Davis. UC Davis has a 27-month program, first year's didactic, where we do all our learning. We do skills, we do like, the learning portion, the book portion of school. And then the following year is our rotations where we're mostly focused on family medicine, primary care, but we also have the opportunity to do other rotations. For example, like I was able to do dermatology aesthetics. I was also able to do surgery and emergency medicine as well. So why PA and why family medicine? So I decided I wanted to be PA first because of representation. A lot of times, I am the firstborn of I'm a first gen student, so my parents don't know much English, and so when we would go to the doctor's office, there was nobody who spoke Spanish at that time. I had to be translating. I was just 7 years old, trying to figure out what these big words meant. So I felt like there was some need of representation. I wanted to see more people like me. I wanted to see more female Latinas out there, representing and then helping our population as well. Because there's one thing knowing the language, but there's another thing knowing the culture and kind of knowing the background of why our patients, might can't control their diabetes. They have a certain diet that a lot of people don't understand. And so being able to understand a little bit of their background from experience I felt is really needed in medicine right now. Another reason was because I wanted to help the underserved. I did grow up, in an underserved community, so I did frequent community clinics that a lot of people who are in medical have the opportunity to be in, and I felt like these people are the people who really needed our help, and that was one of the big drives because I wanted to help people like my parents. I wanted to help people who like my grandparents who really don't have access to healthcare. So that was another big reason why I wanted to do medicine and PA in particular, because here in the Central Valley, we have such a big need for doctors. And so as a PA, I feel like we're able to kind of bridge that gap to help make sure that everybody has adequate care here in the Valley. And then another thing, lateral mobility. This wasn't a big factor, but it's one of my favorite ones because I am able to move from one specialty to another without having to go through another residency or any type of residency. So, right now I'm doing family medicine. 10 years from now, I could do surgery. I could do pediatrics, women's health. The possibilities are endless, and I feel like I am a person who likes to explore. So I felt like this was the perfect career for me. And then other pros that weren't such a big deal, but it's a perk. It is an accelerated program, much faster getting in and then getting out to the work field, and then less loans, of course. So that's always nice as well. And then, like I mentioned, my many interests, I do want to be a part of preventative medicine as well. So that is why I chose family medicine. A lot of times I found myself during rotations like, do I want to specialize? Do I want to do something more broad? And then family medicine really did scare me, not gonna lie. I felt like I had to know everything, and that's what I feel scared me. But at the end of the day, really came down to my interest. And I was like, I want to be able to help prevent patients from having to go see specialists, because a lot of the times, like I mentioned, we have such a big lack here in the Valley that getting patients to specialists is so hard. And what better way than avoiding those situations and being part of the preventative care aspect? And so I think this is why family medicine is so important, because this is where it starts, us helping our patients prevent further progression of their chronic conditions, to ensure that they don't fall in that loophole of like, there's no specialist, they have to wait 1 to 2 years and just their conditions getting worse because there's no access to that health care. And then I also wanted to solidify my learning. I felt like family medicine would have been the best way to make sure I stay fresh with every part of medicine. And then that way, if I do decide to specialize in the future, I feel like I've already solidified what I did learn during PA school, and I'll be able to feel a little bit more comfortable if I do decide to specialize in the future. So to kind of give you guys a little typical day in family medicine, so I do work 4 days a week, 9-hour shifts, meaning that I only do 36 hours a week, which is really nice. So that extra day of the week, I'm able to do my own stuff. Like if I have to go to the clinic for any reason, things like that. So it's really nice that I have the opportunity to do that. I do work one Saturday a month because we try to have access here at the clinic that I particularly work with. We try to open up access for a lot of our patients. Like I mentioned, a lot of my community is they're farm working patients that don't want to stop working, and their work sometimes is only seasonal when the fruit is coming out and things like that. And so us opening the Saturday makes it more available for our patients. So I get to work one Saturday a month, and it rotates within my coworkers. So to start off, I'm pre-booked with 28 patients, meaning that there is like about 15-minute slots per patient with 4 same-day slots. So those slots are specific just for like same-day problems. So if somebody calls in the morning, they're like, oh, I'm having a sore throat, I'm having a cough, I need to be seen today. Those slots get filled up that same day. Those are blocked off. You can pre-book them. As for the pre-booked appointments, those are for people who call and like, oh, I just need a refill, or appointments that I set up. So like if I wanted to do a follow-up for one of my patients in a week, those would be considered our pre-booked patients. Like I mentioned, we get 15 minutes per patient, which, it sounds a little scary because that is the time that, our MAs bring them in, get them roomed, get them vitaled, for me to see them, treat, diagnose, and examine, and also chart. So it can get really busy, especially when we do have a full load. On average, I see anywhere from 26 to 28 per day, but there have been days where I've seen up to 33. And there's also been days where I've only seen like about 23. So it really varies. But my clinic, it does get very busy because it's one of the very few clinics in that area. But it keeps me busy, so it makes the day just go by so much faster. So I do see patients from 6 months and older. 6 months and under stays with peds, but I get to see the babies as well once they're 6 months. I do anything from child checks, acute diagnosing, and my follow-ups for like anybody who has diabetes and chronic conditions like that. I do have my own patient panel, which I think is very neat. So I am PCP for some patients, and so I am able to follow up with them. And then whenever they need anything, usually they get sent to me. Obviously, when we're too booked and, they do have an acute, a cough, something going on like that, they are able to see any of my other colleagues. But usually when it comes to their management of their chronic conditions, I'm able to follow up with them. And I've been a PA in family medicine for about a year and a half already. So, I've been very fortunate to have a lot of accomplishments that I share with a lot of my new patients now that I've been following for over a year now. So it's really nice to see the progression of our patients, to see how much they've improved. And not only that, just to see that their change in health and overall, it's so gratifying to see our patients achieve their health goals, and then they are so appreciative, which makes us even more rewarding than it already is. And I love to do procedures. I love to be hands-on, and so I am able to do a few procedures during procedure blocks that I have at clinic. So I do anything from joint injections, aspirations. I also do toenail removals, skin tag removals, INDs, suturing, just to kind of name a few of those things. So if I could do procedures all day, that would be awesome, because I just love being hands-on. So that's the beauty of family medicine. We're able to do a little bit of everything. So now we're going to go into some patients. So we're going to go into cases, and then we'll kind of just walk through them kind of in the similar format that I would while I'm in clinic. So patient 1, we have Mary Jane. She's a 67-year-old female coming into the clinic, and she says she has a rash on her back. So what kind of questions should we ask? This is the first thing that whenever I see my list of patients' chief complaints, I start to sit down and say, what kind of questions do I need to ask my patients in order to be able to diagnose them appropriately? So I like this little acronym that I learned in school. It's old cart. So that pretty much tells us what we need to go over. So the O stands for onset. So when did it start? The L is for location. So where is the rash located? D is for the duration. So is it an on and off thing? Is it constant? Have you had it in the past before? Is it recurrent? Things like that. The C is for the characteristic. So like for in this case for her rash, does it burn? Does it itch? What's the color? Is it dry? Is it wet? Is it purulent? That's kind of the way we want the patient to describe that to us. We also ask the A is for aggravating factors. So what is making it worse? What triggers the pain or the rash if it's an on and off rash? R is relieving factor. So what have they tried? What makes it better? Have they tried a cream? Have they tried medicine? Have they tried home remedies? Any of those things could be part of our history taking. And then T is for treatment. So medicine, home remedies, like I mentioned. And then S is for severity. So always ask like, how bad is this affecting you? Is it from a 1? Are you able to do like a 1 to 10? Or just ask them how is it impeding in your day-to-day life if it's something more chronic. So to kind of go back to Mary Jane, she said it started with a pain sensation about 3 days ago, and then the rash later developed a day later. It's located on the left side of her back, and she said it kind of wraps around the left side of her side and her chest. She says the pain is constant for her. She describes it as a burning sensation rather than an itchy rash. Aggravating factors, patient says that anything that touches it or rubs against it makes it flare and trigger. Patient mentioned that she tried Tylenol, but it doesn't resolve the pain. Any other treatments beside that, it was just Tylenol that she was taking. Her severity is a 9, so as you can see, it's a pretty severe pain that she is experiencing. And then we ask past medical history. It's also very important to know because we want to know different things that could be triggering this current condition. So first, we know that she has no known allergies. She's never had any allergic reaction in the past. So if this is an allergic reaction, it would probably be her first. She does have a history of chickenpox. But she has no vaccinations at all. She was never vaccinated as a child, and she hasn't been up to date with any vaccines. We also ask, especially when it comes to the skin and rashes, we always want to ask, have there been any changes? Any new lotions, soaps, laundry detergents? She denied all of that. And then we also ask about anything that she ingested, foods or medications that she might have changed, because a lot of times people start medications and then a week or so after they might develop a rash as well. So we want to make sure that we rule out those things as well. And then she has no exposures to plants or shrubs, says she's usually inside, doesn't really go outside. She doesn't do much of gardening, so she hasn't been exposed to any of that. Now on physical exam, this is what we see. So as you can see, it's a dry red rash. Looks like there's some blistering here. Hope you guys could see my mouth here. So there's some blistering areas here. There's some crusting but blistering here in this aspect. And as you can see, it kind of wraps around this area. And so what we would call this in medicine, it's going in a dermatomal pattern, meaning it goes following one of the dermatomes. So usually unilateral, only one side, and it follows kind of like if it were a band around. So now we have to think of our differential diagnosis. I like to think this since the beginning, since even before I go in to see the patient, I like to come up with differential diagnosis for just seeing the chief complaint. So it was a rash. So what potential things can it be? So at the top of my list, especially after this exam, it's shingles. So patient mentioned that she didn't have any vaccines. She does have a history of chickenpox, and she describes it more of a burning, painful vesicular rash. And again, like I mentioned, it follows that dermatomal pattern on her back, especially just on one side. But other things we want to keep in mind are also things like contact dermatitis. So with contact dermatitis, if anything she came in contact is causing a rash, usually wouldn't follow a pattern. It might follow the pattern of whatever the triggering or aggravating factor is, but it wouldn't follow just a unilateral dermatomal fashion. And then patient did deny any exposures to any new like ingested or topical items. And since her rash is not itchy, it's not a big factor, but it's one of the most common, especially with contact dermatitis. Rashes do tend to be more itchy rather than burning or painful. And then urticaria as well. For this one, it would be a little bit different. You would see more of the welts, so it'd be like patches over the skin. It wouldn't be too vesicular, and then it wouldn't have like a well-defined pattern. So it'd be kind of going all over the place, or maybe usually all over the back. So patient mentioned that the rash wasn't itchy. She doesn't have any food or medication allergies and hasn't been exposed to new ones at that time. So with this patient, I diagnosed her with shingles. It's a very textbook picture of what a shingles breakout would be. And so shingles is caused by a varicella zoster virus reactivation within the sensory ganglia. So usually patients who have had chicken pox in the past have the varicella zoster, but it's dormant. And so sometimes there's this reactivation causing this type of rash and pain like the patient described. Shingles is very contagious, especially with direct contact of the lesions. So for us to ensure that a patient isn't contagious anymore, we must ensure that the rash is dry, make sure it's crested, and that's how we would be able to determine if a rash is no longer contagious. So for treatment, usually this is a virus. So usually with viruses, there isn't like a treatment, but there is things that we can do to help the process. So usually with antivirals, it helps speed the healing of the lesions. It also helps with decreasing the time and the severity that the patient will have this for. And it also prevents new ones from coming in. So usually we do something like acyclovir or valsaclovir. Those are the most common ones we use. They are usually pretty good, like both of them. They kind of are pretty equal, but usually a lot of people tend to go for the acyclovir more because it has demonstrated to be within the short time frame to be help a little bit faster. Other things that we have to consider, especially with this type of diagnosis, is control for pain. Pain varies for people differently, especially when it comes to shingles. Some people might have very mild pain where Tylenol or ibuprofen can help, but sometimes these aren't enough. Sometimes people might need narcotics. Sometimes they might need gabapentin, which is a medication that helps with nerve pain. And so we have to really gauge how the patient is feeling, ask them how bad their pain is. That's why it's very important since the beginning to kind of establish that, to kind of determine if we need to start them on something stronger or if we could typically do just the Tylenol NSAIDs. So for this patient, I decided that we were going to do gabapentin as well, along with her antiviral, because she was having very significant pain. And we wanted to ensure that, this patient was comfortable while we're kind of waiting on the healing. So patient number 2, we have John Doe, who is a 32-year-old male. So he's presenting today with complaints of right hand pain and finger numbness for about 2 weeks already. He describes this pain as a dull, aching pain. Patient is right-handed and he has been a chef for over 2 years, so he works a lot with his hands. He says the pain is worse during work and at times it does wake him up at night, but he says he just kind of just shakes it off and the numbness goes away and he's able to go back to sleep. Patient has tried ibuprofen. He's tried massaging the area. He says he gets some relief, but he's really concerned because it's just affecting his lifestyle now because pain is not completely going away. And like I mentioned, it's now affecting his job. He denies any weakness, any swelling. He hasn't had any recent injuries or injuries in the past. So on physical exam, especially when we're testing for anything pain-wise in the wrist, there are 3 special tests we kind of want to look for. So we want to look for phalanx, which is a test where we have the patient flex their wrist in this type of position, like we have in this picture here. We have them hold that up for for about 30 seconds to 1 minute. And usually what this will trigger is some numbness in the fingers. So if this happens, that's a positive valence test. We could also do something like Tinel's test, which is just tapping at their wrist while their wrist is extended. And what this will elicit is, again, that numbness and pain in the fingers. And then the Durkin test, which is on the bottom, this is just doing compression of the wrist. At the picture right here that we have at the bottom, that one is a combination of the Durkins of applying pressure at the wrist and the valence at the same time. So what this will trigger is some pain and some numbness sensation as well. And then we also want to look for other signs, like make sure there's no swelling, look for any redness, any bruising. A lot of times patients might forget some, like, a certain injury that they had and they don't realize it. So, also important to make sure that we don't see any swelling, deformities of the wrist as well. So now we kind of form our differential diagnosis. So top of the list, we have carpal tunnel, which would induce numbness and pain in the hand, but things like cubital tunnel could also affect. And then we have tendonitis due to the overuse that this patient did have. It's also another possibility, and a ganglion cyst is also another possibility, but usually that would be visible on exam. So you'd be able to see like a little bump or a mass on either sides of the wrist that could be causing compression in that area. So here's just a little diagram to kind of show you what, carpal tunnel is. So here we have the carpal tunnel. So it's pretty much like a little tunnel that we have here. And then our nerves usually go in through that area. So as you can see, the median nerve, if this tunnel right here, this tendon is inflamed, there's some compression going through this median nerve. And so when there's this compression, it causes numbness and tingling. It causes pain in these particular areas, to be exact. So usually the people would usually say in these four fingers are having that numbness and tingling, which you'd be able to distinguish from cubital tunnel, which is usually on the elbow. We also have a tendon there that could also become inflamed, causing compression. But usually with that, you'll have numbness and tingling in these last two fingers because of that. So here's just a little more description of like where the area of the median nerve goes through, and these would be the areas where people will endorse the pain or the numbness. So I'm sure you guys kind of get the gist. We carpal tunnel is at the top of our list. So usually I love Up to Date is one of my favorite resources to use in clinic, and so they have these neat diagrams that help us when it comes to trying to figure out the best treatment for our patients. So we'll kind of walk through this. So patients, the diagnosis for carpal tunnel is clinical. So we don't really need to do imaging. We really don't need to do further testing to make this diagnosis, because a lot of the times, patients come in, their whole history tells us exactly what it is. So there's things that we have to consider. So are the symptoms moderate to severe? And do they include any of the following? Is there numbness that is continuous, weakness that is continuous? Is their sleep being disrupted with pain? Or is there impairment of their hand function? So if we kind of go back to what our patient described, he said he does wake him up, but he's able to shake it off and able to go back to sleep. He says it's usually worse at work, meaning that it's not there constantly. But he does mention that, he is having a hard time with work. So, with this one, we could either go both ways. So if we decide that, it is causing very severe impairment to our patient, we go down the yes portion. And so is the patient pregnant? So our patient's a male, so no. If this case was severe, we would probably do testing, and this would test the nerve innervation to make sure that it is still doing what it's supposed to do. Then depending from there, we could either do, if there's no loss of the or denervination, we could do non-surgical measures, which would be wrist splinting, steroid injections, and then we do a reevaluation to determine if we need to do further treatment. If it's very severe and we see that there is some axonal loss, we would refer the patient for surgical decompression. So usually, like I mentioned, especially at the clinic that I work at, a lot of our patients, for one, they don't have insurance. So it's very hard for them to see specialists who do like low income programs for them. So a lot of times we have to try to do the most that we can here in family medicine. So when we go with the non-surgical matters, we always do splinting first. So I'm able to provide my patients with splints at work, usually tell them wear them at night, especially because it does hold their position, their wrist in a certain position, which could possibly make it difficult for them to work in. And then after I give this, we do an evaluation again in 1 to 2 months, depending on how symptoms are. If they're persistent, we obviously want to so refer them, and then a lot of times we do injections in this area. So that is one thing that I was very fortunate to learn during my PA school rotations. And so with steroid injections, we're able to kind of relieve that inflammation of that tendon to decrease the compression of the median nerve, which ultimately decreases the symptoms that patients are having. A lot of times our patients, don't want to leave time from work, and so they can't get a surgery, so that's not an option for them, and the steroid injections provide great relief to our patients. And so to kind of give you a picture, these are the splints that we use. Usually in this area there is a metal rod that kind of keeps the wrist in a certain position, which helps kind of decompress that pressure that the median nerve is undergoing when it is in a more flexed position. And here are the areas when we do steroid injections. So we usually typically go to this little area here, like about 1 centimeter from the wrist crease. And we kind of want to go inside to get the area where the carpal tunnel is. So a lot of times, some patients who have the palmaris longus tendon here, we're able to kind of use that as a guide point of where we want to inject. And so I have this small sample video that I found online. This hopefully try to play it, and hopefully you guys are able to hear it as well.
I don't think the volume is going through. Do you have volume going through on your end?
Yes, I'm able to hear it. I think it might be because I have the headphones in. Let me try it with them. Did it work at first? No.
I'm not hearing any audio so far still. I was hearing something in the beginning though. I don't believe the audio is going through, but if you'd like to narrate or whatever works.
So as you can see, there's two different ways that they're doing them now. So one of them is more invasive, which does take much longer for patients to recover from. And the other one, it's much simpler and it's helping patients recover much faster with that one.
Laura, just one thing. I don't think the audio actually went through. I think it was still on your AirPods. Can you
Oh
just give us
no.
a quick narration of what happened? I heard that
Yeah.
there were two ways of going about things,
Yeah.
invasive. Okay.
Yeah, so I do apologize for that. So the first one, usually, what they're doing is they do a full incision from, somewhere around here in the wrist, in the palm, and it goes down to the bottom of the wrist. So when they do that, they open up and they dig through the tissue to get to the ligament that is what we call the carpal tunnel ligament. And so in here, then they do a release. And so they pretty much cut through it to release the pressure that the median nerve is going through. So that one is the most invasive one. And then the second one is now with the endoscope. So they're usually two incisions that they do, one from one side for the camera, the other one is through the other side for them to cut through and do pretty much the similar procedure, but just without having to open up the arm and the tissue layer as well. So usually that's sutured back up, but this usually gives patients relief because now instead of that tunnel kind of compressing the wrist, it is now open, allowing the median nerve to be released and the numbness and tingling should resolve with it. Okay, and so that's all I have for you guys. Hope this was helpful. I'm open to any questions, help with clarification, or if you guys are just any questions about what it's like to be a family medicine PA, I'm more than open to sharing a little bit more.
All right. Well, first of all, thank you, Flora, for taking the time to get this all together. I know we have quite a few pre-PA students who absolutely love our PA speakers, and it's been a while since we had a PA speaker on. So thank you again. But just to get started, by the way, as we go through, feel free to drop more questions in the chat. For those of y'all listening, we'll have a good amount of time for the Q&A so we can get through a good number of questions. But just to get us started off, I wanted to ask, you chose your major in psychology, right, for undergrad. Do you
Yeah.
feel like that played a part later on as a PA in any way?
I feel like I have a different, aspect of my learning because my psych studies focused a lot on learning, and so I felt like that ultimately kind of helped me learn how to learn myself. And I felt like I was able to see a different aspect of, a lot of times, psychology isn't considered a science for some, and I felt like I was able to have outside knowledge, especially when it comes to mental health. I feel like a lot of times it's neglected in family medicine because we think of the patient as a body and we kind of forget the mental health aspect of it. So I felt like that kind of helped me always be a provider that's always not just thinking of my patient as a body, but thinking of their mental health as well. So I feel like it has played a role in my not only my learning, but also in my career.
And earlier on, you mentioned how you ended up getting into your dream school despite having a GPA on the lower end. Did you have to retake any of your prereqs to boost your
So
GPA?
So I was very lucky that I got accepted my first application. So I was on the wait list. So during that time when I was waiting to hear back, I was taking as many science courses as I could. So, I was limited because I was retaking them at the community college level and I was working full time. So it was going to be a little bit difficult if I try to take them at my state university. So I did them at the community college. I did retake biology. I also took other classes that I hadn't had the opportunity to take. So I did like human health. I also did health and safety class as well. That also counted for my science GPA. So while I was waiting, I did retake classes, but ultimately I really didn't need those grades because I had been accepted the first cycle.
Definitely goes to show that hope isn't lost, no matter how bad it might seem. But
Yes, for sure. I was actually accepted a month before school started. So I was already at that point, I was already on the second cycle. School started in June at UC Davis. So I was already, I was preparing my application again. I had opened the CASPA application again for the April because they opened up in April. I was putting up my GPAs together. I was getting my new transcripts because I really thought I'm like, oh, it's too late now. But yeah, last minute, I was able to get in.
That's great. That's great. Did you end up having any time to unwind before PA school started? Vacations or anything like that?
No, because there was so much things that I needed to do. There was a lot of onboarding things, the financial aid aspect. I was still working. So, I still had to put in my 2 weeks. I couldn't just go up and quit. So I also had to do that. And I felt like everything was just so fast that I didn't get much time to decompress. But I felt like my gap year allowed me to kind of do that since I was just working full time, taking one or two classes. It didn't feel too crazy that year that I did take off.
All right. Well, we have quite a few more questions. Also, just generally about the application cycle. Um, how much of a part do you feel like it plays to apply early in the cycle? How relevant is that in the PA sphere?
Yeah, so I get this question a lot because there's people who are like, I want to turn it in that first week. So I usually tell people if you feel like your application is ready, you've run through it and you feel confident that you don't have any mistakes, feel free to turn it in the soonest you can. But a lot of times what happens, people try to speed through the process that there's mistakes sometimes with whether it's a GPA, the way a class was inputted, it doesn't match with the transcript, things like that. And so then that just kind of delays the process. So I would say take in consideration the schools you're applying to. So for example, I applied to four schools, I believe. Two of them were rolling admissions, and two other ones were once they get applications, then and they close application cycle, that's when they look at applications. So I felt like I really didn't have much of a rush, especially for UC Davis, because they close applications and then they take a look at your application. They take a look at everybody's application. Other schools go rolling admission, so they'll put that in their websites. They'll say we are on a rolling admissions, meaning that they go through the applications as they're rolling in. But some do mention that, oh, we are rolling admissions, but we don't start opening applications until like, for example, like the applications open April, they won't take a look until like July. So really pay attention to the schools you're applying to, and see what kind of admissions they provide. That way you're able to kind of gauge when you need to apply. The sooner you apply, obviously the better because there's more chances of you getting seen before other people get seen. But if you're not ready, don't speed through the process because you want to avoid making any mistakes.
Just one quick question, just to follow that up. How many schools did you apply to all in all?
I applied to four schools because I was saying this was my test run. I really didn't feel too confident in my application, especially with that science GPA I had. I felt like my overall GPA was good, my hours were good, but I felt like my science GPA needed a lot more, so I only applied to four at that time.
And it was your dream school, right? UC Davis
Yes,
specifically is the one you wanted to go
yes,
to.
yep, UC Davis was definitely my top choice. So like my mind was set with UC Davis.
Mhm.
But obviously I didn't want to throw all my marbles in one sack. You obviously want to make sure you apply to other places as well.
Absolutely. And to talk a little about the interview process, how was that like for you? How did you prepare?
So for me, it was very new for me. So interviews, I really didn't know how I was supposed to prepare. I had no idea how I was supposed to like, you know, prepare for these things. I only knew like, I needed to dress professionally and I needed to know why I wanted to be a PA. I had recently done job interviews, so I was like, oh, in my head, this was my practice. But definitely something I don't recommend, now seeing it on the other side, I do recommend doing mock interviews, going over common questions that they have online. So, you could find like a gallery of like over 200 questions online, practicing those questions, not memorizing your answers, but learning, like remembering what kind of things you want to review, because a lot of times you don't know what you're going to be told. And if like, I do help students with like mock interviews, and a lot of times I can tell like, oh, this person rehearsed their answer. I could tell that this is an answer that they wrote down, they've memorized, and this is what they're going to say. And a lot of times interviewers don't want to see that. They want to see you speaking from your heart. They want to see that genuine aspect. So just practicing not memorizing answers. And then also looking into the schools, looking at their mission statements, what type of students they're looking for. That way you make sure you align well with the program. So when you are interviewed, you kind of touch on those aspects. So for example, with Davis, I did see that they were focused on primary care, which is something that I knew I wanted to do. I wanted to do primary care. So I was able to kind of speak on that a little bit because that was ultimately my goal. But I wish I would have prepared much more because, like I mentioned, I felt like I didn't have the tools at that time. But now seeing on the other side, I feel like I'm able to kind of give a little bit of advice on how to do interviews and what not to do before your interview as well.
How many classes did you take when you were working full time, and how did you, if you did mention it, how did you talk about it during your interviews, the hardship of working full time while you're taking classes?
Yeah, so I believe I took about one or two classes. One I remember one was in person and then the other one was online. So in those two semesters that I did take classes, I would try to stick to one in person and then the rest I would try to take them online. So I was able to do that. And then I felt like with UC Davis, their interview was a little bit different compared to other schools. We did have a group interview and there wasn't a one-on-one session. So I really didn't have to explain that, but that is something that I did explain on my personal statement, mentioning that, like juggling, working full time while working on my application and excelling on my grades. That's definitely what they want to see. They want to see that you're able to kind of juggle everything, but still excel on what you're doing as well.
And then another student asks, did you ever consider emergency medicine?
No, I cannot work under pressure. I did my rotation in the ER and it was just too overwhelming for me. I feel like it's a personality thing. I am very organized oriented. So I was that one student that had to-do lists and I had to go in order. It wasn't like, oh, let's do this one first and let's do that one first. I was very organized and I feel like that's what I love about primary care and family medicine, is that I have a set schedule. I know what I'm going to see throughout the day. I do have those other four slots that are available for same day acute things, but having that structure, I feel like it helps me kind of ease my anxiety because emergency medicine was just like too fast paced, too spontaneous for me. So I really did not consider emergency medicine.
Yeah, that's fair. Definitely based on, lifestyle, it'll leak into, personal life a bit. So you have to consider that for sure.
Oh, yeah, that's another thing for sure.
And going back to your application, a student asks, how many patient care hours did you have overall when you applied at the time of application?
I think when I applied, I had like the minimum as well. I had like 1,200, I believe, and that was including my work as a CNA and my volunteer work at the hospital as well. And then I did have some shadowing experience because I was very fortunate to get an internship where I was able to shadow a pediatrician. And so I had about like 100 hours in like shadowing experience.
All right. We have a couple more questions. I think we'll be able to get to all of them by the end of the hour. Our next one is, did you feel as though you were prepared when faced with doing procedures on real patients during your clinical year? And if so, how did your didactic year prepare you for that?
Yeah, so it was tough for us, especially as that graduated in 2021, 2022. We are COVID students. So, we when the pandemic hit, I think I was barely like I believe like 6 months in to PA school. So I really felt like I did during didactic, I really lacked that hands-on experience because we weren't able to do a lot of our hand-on training during didactic year. A lot of the stuff that I learned, like procedure wise, was during clinicals. And I was very fortunate to work with a doctor. His name is Dr. Bautista here in Fresno. And he really threw me in there. Like, he made sure I was comfortable, but he told me, like, I want you to learn and we're going to work on this together. And so he kind of gave me that confidence boost to make sure I could do it. And like everything is supervised. And, I'm very thankful that he put his trust in me to be able to help him with these procedures, because I felt like that's the way that I learned, based off of comparing it to like what I learned in didactic. Doing something by hand is very, for me, especially for me, I'm a hands-on learner, so I felt like that was the only way for me to get a good grasp on how to do procedures was by doing them on my own. So yeah, being able to do it on, thanks to like, the preceptors I had, I was able to get a good grasp on how to do these procedures.
I'm not sure if you might have already covered this before, but one student asks, how many classes did you retake?
I think I just retook biology, like the general biology, and the rest were just added on courses, that I had to take during, and this was just my science classes. Obviously, in undergrad, when I was in undergrad, I did have to retake calculus because I had failed it. I had a really rough year that year. It was my second year. I had a rough year that year, and so I had to retake calculus and biology at that time as well.
And again, about your application cycle, did you have anyone to guide you through it, a mentor? The student asking is a first gen student, so it feels like for them, they have a lot of questions, but no one to turn to.
Yeah, so I totally understand. Like I mentioned, I was part of HCOP, but a lot of the students around me were pre-med. And so I was pre-med at one point, until I discovered the PA profession. And so it was hard to find mentors who were kind of going through the same situation. So it was hard because, like I mentioned, I didn't know that I had to prepare for interviews. I thought, well, I did job interviews. I thought that was my preparation. And so I really didn't have, anybody to kind of guide me or tell me, oh, you need to do this, you need to do that. I had, from HCOP, I did have a guidance counselor who was great. Like, he was a doctor though. So his way through medicine was a bit different than PA, but he did help me immensely with, figuring out how to do my personal statement, figuring out how to kind of browse through the school that I wanted to apply to. But I really didn't have like a PA to kind of look up to, which is why I do what I do now. I try to be active on social media. I try to do, mock interviews, try to do, um, personal statement reviews for students, because it's hard being first gen to navigate it because there's not a lot, especially, other people have family members who can guide them through it. And for us, there's not a lot of people that we can go to. So, I feel you, and it's hard, but you can get there. And I'm also available if you ever need some guidance and questions that need to be answered.
That's very helpful. Thank you for sharing that with students. We only have a couple more questions left to wrap up the hour. The next one, I believe they're talking about like weighing out how much you earn as a PA. What does your quality of life look like? If that, for the one asking, if that is not what you mean to say, please feel free to let me know. But I believe that's what they're asking. So if you consider your salary, how do you feel like the quality of life is generally as a PA?
Oh, I feel like it's great. But I feel like it really depends on what specialty. So, for example, if you were to compare with somebody who's an emergency medicine PA to my lifestyle, it's obviously going to be very, very different. Family medicine, usually Monday through Fridays, one Saturday a month. Some holidays are off, and so I don't have to do night shifts. I don't have to do on call, things like that, as opposed to somebody who might work in emergency medicine. They might need to be on call. They might need to do overnights. They might need to do holidays, weekends. And so, a lot of times I tell pre-PAs, do not say that work-life balance is your reason why you want to be a PA, because it really varies for people. There's PAs who don't have that much of a good work-life balance because of the specialty that they might be in. So, I feel like my quality of life is great because I feel like I have those weekends off. I have, that one day in between in the week that I'm able to do things that I need to do as an adult that I can't do over the weekend. So it's been very helpful to have that type of schedule. Um, because I told myself when I was working as a CNA in the hospital, I was like, I cannot do this for long term. I was like, 1 year was enough of doing weekends, of doing holidays and overnights because I was an overnight CNA. So that was rough. And I'm like, it just took 1 year for me to be like, nope, I want to do something that I'm able to enjoy time with my family as well.
We know emergency medicine wasn't for you, but were there any specialties that you feel outside of family medicine that you were drawn to or you considered before going forward?
Oh yeah, for sure. I love pediatrics. So pediatrics, I was actually when I was pre-med, when I was back in high school, I wanted to be a pediatrician. I was like, I want to work with kids. I have such a big heart for like working with kids, which is why I was a second grade tutor while I was in undergrad. So I have a very soft spot when it comes to kids. So I was always set with peds, and I loved my peds rotation. I was really thinking maybe I am gonna do peds. But then I did women's health and I fell in love with women's health. I did orthopedic surgery and I really came to love that. And that clinic also did sports medicine. So I did a lot of sports medicine as well, which is where I learned a lot of like, my joint injections, carpal tunnel injections, shoulder, knee, joint injections. And so I felt like I really liked that. And so since I was so undecided, I felt like that's why I chose family medicine because I'm able to do a little bit of everything. 1 minute I'm a dermatologist, the other minute I'm doing a toenail removal. So I feel like it's the best of like all the worlds in one. So there's definitely things that I'm interested in. Maybe who knows, 5, 10 years from now, maybe I'll decide to specialize. But I think for now, I'm happy where I'm at.
Well, that's a fantastic place to wrap up today's session. This was such a wonderful session, I have to say. I I learned quite a bit, especially during those cases. And I mean, the enthusiasm that you have for what it is to be a PA and family medicine in general, it's really admirable to see, Flora. So we have to thank you again. And though for those listening in the chat, we'll hear from some thank yous from you too. We've already heard quite a few thank yous over the chat as you've been answering these questions. But yes, thank you so much, Flora, for all of it.
Thank you guys for having me. It's a pleasure. And you guys, I'm not sure if you guys will share like, my information, but like, I am active on Instagram and I do have my email and I'm like, open to like, any questions, things like that. I do offer these services for free. I know a lot of people charge for personal statements and reviews and mock interviews, but I do offer them for free because I just want to be part of, of somebody's journey and just help out because I know how rough it is.
Absolutely. I do have a couple reminders for y'all who are listening, and towards the end, I'm going to drop in the handle for Flora, her Instagram handle, if y'all would like to get in contact with her. But just for y'all listening, I do have some reminders for y'all in terms of our quiz. We posted that quiz in the chat, or actually, I'll post it right now. But this quiz is a Google form, 10 questions. All you need to do is have 6 or more correct in order to pass. And once you do pass, you'll receive a certificate. That certificate will be sent to your inbox, your email inbox, the one that you list. And from there, I just sent it in the chat. From there, you'll be good to go. That's how we track shadowing hours. That's how you can self-verify or tracking your hours with that certificate. And that quiz will be due on Sunday, November 12th at 11:59 p.m. Central Standard Time. Just be sure to be done with it before then. Again, you only have to have 6 or more questions out of the 10 correct. And for our next shouting session, we're going to be joined by Megan. She's another PA who practices colorectal surgery in the UK. So we'll see how this specialty carries on to another country. And we'll see her at 7 p.m. Central on Monday, November 20th. Between then and now, we might have some sessions scheduled during November. And if we do, y'all will know through our Instagram page or through our listserv. Again, if you want to stay tuned with more sessions, those are great ways to stay connected. But to wrap up today's session, Flora, would you mind sharing your Instagram handle for those interested in getting in touch?
Yes. So my Instagram is PA_Rodríguez 5.
And we'll have that we right now have it in the video description I just saw. So if y'all want to check out her content or just ask a question, she's more than happy to help. We really appreciate that, Flora. It really means a lot to our students. So again, thank you. And I hope everyone has a great rest of your night. Enjoy.